less in Indian patients as compared to their Western counterparts. So these are the studies which have been published in peer-reviewed journals. The cost, in fact, the cost of surgery, if you put in a lens, and because the aphakic patients have to come for repeated follow-ups. In fact, if you consider the blind person years because of aphakia as compared to patients with IOL, the effective cost in IOL patients is much less than in aphakic patients. Again, these are the studies. So what are the points which are in favor of IOL implantation at 6 months? So there is no statistically significant increase in complications. Glaucoma, in some of the studies, there is less incidence, less refractive surprises, especially the myopic shift is less in Indian patients because of obviously the better IOL formula, pediatric IOL calculator, and crisp surgeries by Indian doctors. Visual axis opacification is less in IOL group, better unaided vision in intraocular lens group. Indian surgeons have better surgical dexterity and experience. So there is better instrumentation, good microscopes, good OVDs. So obviously it is cost effective. There are less number of surgeries. So these are the various studies which favor lens implantation at 6 months versus aphakia. In fact, one of the neglected point is childhood blindness because of aphakia. In fact, Parikshit was one of the author in many of these landmark studies. So if you see uncorrected aphakia, that is one of the important cause of childhood blindness in India. And many of the patients, they are from the remote rural background. They don't come for follow-up. They're amblyopic. So the childhood blindness is more in uncorrected aphakia as compared to IOL group. So again, these are the various studies which favor IOL implantation at an early age. See the list. So I think that we should all understand the importance of time and the importance of time to change for the better. Because I would like to quote Roosevelt that future belongs to those who believe in change for the better. Because change is the only constant in nature and life, and change paradigms of infantile IOL surgery have changed the quality of life of those tiny tots for the better. So that's the importance of timely intervention. We should always respect the time. So I think with the permission of the chair, I would like to quote a famous share by one of the famous Indian poet, Bashir Badr, who tells us about the importance of time. तो वक्त को समझना समझदारी होती, वक्त को समझना समझदारी है, और वक्त पे समझना जिम्मेदारी. Thank you if I can understand.
Okay, so after 2 minutes, 1 minute. Yeah, okay. I think let's me hear from the house. How many people for no lens at 6 months? All right. And how many for lens? I think almost equal. Okay, so I think what they said is that I think anybody who's operating here, the first thing about the myopic shift, you have to follow these patients, whatever you're getting, especially the unilateral ones, because what you do is when you follow up, you have a cohort of the patient in which you know what is happening to normal eye vis-a-vis the growth of the eye. So we did a study at the RP center in which we took the patients less than 6 months, 6 months to 1 year, 1 year to 2 years. We followed each group for 6 months, and all, in fact, they're finishing 1 year. We realized that the undercorrection which we do, we don't need that much as the Western, what all these people are doing in the past. So IOL, and especially unilateral cataracts, contact lenses in Indian setup is a big no. The environment things. We had a guy coming over from Leicester who did some lectures at our place. He's got 205 patients in his entire career. 50% are unilateral with contact lenses. In that environment, yes, it works. In Indian scenario, you have a dropout of about a 7.3 contact lenses per year. So if you put the cost of that, it's mind-boggling. If Eki glasses, I see he said rightly, the parents, the poor patient will buy maybe one pair. If it's broken, maybe the second pair. Third pair, I think they're iffy because they don't have money. So I think even if you leave a glass with a refractive undercorrection or overcorrection of ±2, you've still got a target. So what I think that 6 months, if you have everything with you, you're able to calculate the power properly, and you've taken the seismic indication into consideration, and you checked for the cataract glaucoma setup. Most of these glaucomas will happen if they were pre-operative only there. We have missed out. All these studies from Australia et al. Group, these people had talked about glaucoma. It was already there. Anterior segment dysgenesis. Those eyes are abnormalized. In those ones, maybe you can think about not putting implant. If the health of the eye, the size of the eye is good, any is axial length which is more than 18 millimeter or wide to wide more than 10 millimeter, I think you can go with the lens. And doing an explant in these patients is not impossible task, and you're doing a justice to this patient, right? Okay, thank you.
Thank you. Thank you, Professor, for those really valuable nuggets. I would now request Professor Rohit Saxena to start the second debate. I would request all the speakers to stick to time because even our inferior oblique speakers, which were not supposed to come, have also come. No, I'm not saying not supposed to come. We didn't get a confirmation from them. So they are also here. So we want to really fix it in time because everybody has to be back here by 11:30 so that they can go to the next sessions.
Thank you. Yeah, obliques come obliquely. So I'll be talking about pharmacological control being better than optical for myopia. And we'll just see how the response comes from Jatinder. Basically, the fact is, as has been mentioned, there is huge evidence, and that's what we actually always would look at. So huge evidence on the great efficacy of atropine per se, and that is for over 50 years or so, that atropine has been proven to be effective in preventing progression in myopia, and low dose atropine in the last 20 years or so in significantly retarding the progression of myopia progression. Not only is it an evidence that it prevents that, there is a very clear dose dependent response actually scientifically proving the fact that the drug is effective. In India also, so always we keep saying that maybe it's valid for the West and not for us, but even in India now there is adequate data available, including a placebo-controlled, double-blind, randomized, multi-centric trial that has shown the efficacy of about 50+% in reducing myopia progression over a year. There are very, very few studies on the role of myopic spectacles and mainly DIMS, which has very recently come out with a 6-year data, very small, about 100 eyes, whereas the sum total of atropine data would be more than a few thousand eyes over 5 years. So we are actually talking about a huge data, huge evidence. There is no evidence among Indian children about the efficacy of these dim spectacles, and you can just compare the efficacy, 50 to 70% by most studies on atropine and barely 30 to 40% by most studies on the spectacles. Affordability, India is a very price sensitive market. Atropine is way economical as compared to spectacles. It's about 7 times less costly. India, 50% of the population would have 10 to 20,000 as a monthly income, and to spend 16,000 just buying a pair of glass that can break, that can change in the next few months would definitely be a daunting task. So definitely patients always prefer atropine. It's easily available. You just go to any pharmacy, you have a prescription, you can easily buy it. In fact, sometimes when we write atropine ointment for refraction for our children, they come back with low dose atropine because that is the push of the market. So a lot of pharmaceutical companies, India is leading the way. We should be proud of our Indian pharmaceutical industry. Before America, Europe, Africa, rest of Asia, India has been pioneering and has actually sending these drugs across the world, including the European market. Getting commercially DIMS or any of these spectacles is a challenge. Only few and very expensive shops would be having it. They need to center it well, they need to cut it well. There are a lot of issues in this, and just in case the child is uncomfortable, the parents are really tearing their hair on the cost that they have spent with very little return. There is no special frames, no techniques, nothing when you're worried about atropine because you continue to wear your single vision glasses. But here again, prescription is important. You need to be very accurate when you're prescribing, and of course the various frames, they should be larger frames because that's how the mid periphery is going to be effective when you're looking at the effect of these DIMS glasses. There is a lot of talk of peripheral refraction that is going on, although there is no clear evidence that it is an important thing. But then these lenses work on the concept that there is peripheral hyperopia in these children, and therefore you should actually be only prescribing them in children who have peripheral hyperopic refractive error. So again, this is not something that is easily available. In fact, even in our center, we're just struggling to acquire something like this. Atropine is approved for now over 3 years. DIMS and all these spectacles have no approvals in India, at least at the moment. So they are officially off-label use. So, I mean, I would say there is no doubt as to the best available option that I would offer to anybody I know regarding their use in myopia progression. So thank you very much.
Thank you so much, sir. So when sir says you have to use this, you have to use it. You don't have to question his intelligence, his knowledge at any point of time. I have worked under him also. So yeah, I mean, if he says that atropine is good, atropine is really good. There was, I'm not arguing that atropine is not good. In fact, few years back, okay, so I was trying to unhide some slides because of some of the things which he said. I had put it, but I had hidden them, thinking that that will not come up. So I will show you those slides also. So the first and foremost point is that, you know, compliance is a huge issue. If you have your own kids in whom you're putting atropine, I'm pretty sure it will be a tough task when it comes to compliance. Glasses, compliance is not an issue. So cost is definitely an issue, and that is why which one is better? They're complementary to each other. We just presented our paper yesterday saying that in patients who are not responding to atropine, this is a good idea, because once you have, you know, shot all your arrows, what is there in your armamentarium is DIMS or Stellest. And there is, okay, for atropine, I have been using atropine now since 7 years, since 2014. I used to reconstitute it. We presented our paper in 2018. I definitely agree with him that I have more than 1,500 patients on atropine, which is a huge number compared to what DIMS is. Obviously, it is a new thing, so numbers would be less. There is no doubt about it. It's a new thing. It is expensive. Most of the multifocals, when they came to the market, there were a lot of things which came to the market which were very expensive. We are using them because they are effective, so we are using them. So there is an evidence here that how DIMS works. At least there is an evidence. In last 8 years, we have been trying to find out how atropine works. We are yet to find out. Three years back, I was on the other side of the debate with one of my teachers. I was talking about low concentration atropine, and sir was talking on whether it works or not. And my final line was the damn drops work. So I completely agree with him that atropine works. What is next to atropine? Atropine is there. There is no doubt about it. That is the benchmark that has to be started when there is a myopic progression. The word is myopic progression. So these are some of the studies. 2 years, you can see there is 2 years clinical trial rate. I mean, there 2-year follow-up, 6-year follow-up. So it is not new. It is new in the country. It is not new to the world population, because India is a cost-sensitive thing. So they have introduced it late in the market. How does it work? It works on the theory that, you know, so basically the peripheral retina is responsible for the eye growth. That is the theory which was given by Earl Smith. And that is what was being questioned, because it has been done on Macau monkeys, not on humans. But this is the DIMS lens we are talking about, 6 years experience. This is how it creates a myopic defocus, and that is how it controls. This is the data. Since I knew we will be talking about the data, so this is the data. 2020 they published their 2-year follow-up. 22 they published their 3-year follow-up, and they published their 6-year follow-up. Now there are a lot of holes in the study we can find in most of the studies, because most of the authors who have published these studies, I'm countering my own this thing, but most of the authors that have published are on the board of research committee of Hoya. So we have to take everything with a pinch of salt. My own experience, I have used it in 10 patients of non-responders to atropine, and it has worked in them at least for a year. I don't know how it will be in the future. Why 10 patients? That was the question which was asked by the judge, because it is very expensive. I mean, we are in private practice, it is expensive. So yeah, there was a point that how to do peripheral refraction. Just this is what I have drawn it myself in my OPD. We tried to make a new device so that it becomes cheaper to measure peripheral refraction. And this is what we came up with. This is with a 3D printer. We made a small attachment to the retinoscope. And this is can we mute the sound? Thank you. Thank you. So this is a device, you can attach it on the retinoscope. This will measure 22 degrees temporal and 22 degrees nasal for you. So this is a simple device. You can, and one of the good articles is that, you know, whether you turn your head, your eye, it doesn't change your peripheral refraction. This is published in ophthalmology, physiology, and optometry. So you can move your head, you can move your eyes, but you need to find out 20 degrees, 30 degrees temporal. This particular attachment measures exactly 22 degrees temporal, 22 degrees nasal. So those are my arguments. I would again say that, you know, it is complementary. It is not, I have never used it as a primary treatment to myopia progression. Thank you so much.
Thank you, Dr. Jitendra. Yes, sir.
So the ones who didn't respond to atropine, did you add these glasses add-on, or that you stopped atropine?
No. So
It's like an adjunct now.
yeah, I used the word adjunct. We pre-atropine, the progression was 0.86 diopters. Post-atropine, it reduced in these particular patients to 0.7. And since it was more than 0.5, we started on DIMS, and then it reduced to 0.3. But that is only 10 patients. There's a huge number of patients who respond to atropine. Yes, sir. We did not, because atropine has a rebound effect. So once I stop atropine, they will come back, and the glasses, we won't be knowing what glasses is doing. 6 to 12 years, sir. Yes. Yeah, house. I don't know. Oh, sir,
What does the house say? I think
okay, how?
one side the parents are taxed, the others, I mean, the parents are taxed either way. Either you put the drops or you get the pocket chopped. So
No, so who all uses low dose atropine? And who has used DIM so far? Yeah.
I think low dose atropine, lot of things we don't understand as of now. I think as a lot of research is going on in experimental and in human setup. So I think in another couple of time we'll be understanding a bit more how it actually works.
and the other
But
thing
it
is,
does work. There's no controversy about that.
yeah, the other thing is you can stick on to your retina colleagues. If they're seeing the ROP patients, when they do the lasers in these patients, mid-periphery lasers, those are the eyes which grow much faster. So that again is the peripheral blur which kicks in.
Very true.
So that's the most important thing. So we have a retina people who associated with us. So we switch over to their side when these patients come, and we realize they can go out of proportion. Those eyes you just cannot predict. If you've done half laser or full laser all around, it will make a difference. So I think there's so many things we don't know how atropine works. But yeah, the DIMS I think has more physiological optical basis.
In fact, those who had laser and those who had cryo and those who had anti-VEGF, there's a lot of difference in what you were saying.
Yeah, the anti-VEGF group doesn't go that bad as the laser or the cryo group. Cryo nobody does now. It's a laser now.
Yeah.
Thank you, professors. Now I would request Professor P.K. Pandey, sir, who is the doyen of strabismology in India, and to speak about early surgery for infantile esotropia. And we'll be having Professor Swati Fulzare from the All India Institute, who will be speaking against it. And then perhaps Professor Dadia can make some comments on it. Doctor.
Thank you, Dr. Parikshit, for a very nice introduction. Yes. So we must understand that we came from the ocean and we had two lateral eyed situations, the two monoocular visual systems which are fully crossed, and there is no half cross chiasma. Now, once we got frontal eyed, the two eyes got crafted onto each other and we have fusion. Now, whenever there is problem with fusion, we go back to primitive monoocular visual system. So it is very important to understand that this problem is lying more with the brain than with the eyes. As ophthalmologists, we make this mistake that we are treating at the level of the eye, but the problem is mainly at the level of the brain. So whenever there is problem with cortical wiring, we return to the primitive monoocular visual system, which is in lower animals, and you will accordingly will have primary inferior oblique overreaction or superior oblique overreaction, DVD, which comes from dorsal light reflex. Inferior obliques and superior obliques are very important in fish or animals which are marine, because they have to go down and go up. So the inferior oblique, the oblique muscles, which were very prime movers have become secondary movers as we have evolved into frontal-eyed animals. So whenever there is a problem, you will have inferior oblique overaction, superior oblique overaction, DVD, DHD, DTD, nystagmus, and smooth pursuit asymmetry. So all these things follow as a consequence. We must understand that the neonates don't have fixation. They learn fixation by about 6 weeks of time. So whatever has to happen, there has to be fixation first by 6 weeks and later developments. So everything is time bound and has to happen at a particular point of time. Now, if we don't rectify this, there is going to be a major problem. There are conditions which are associated with infantile esotropia. Not that it is always seen with this. Most of it, we say that there should not be any CNS involvement. But it is well known that if you have cerebral palsy, if you have prematurity, if you have low birth weight, Downs, intraventricular hemorrhage, and PVL, then the incidence of infantile esotropia goes up exponentially. So there is a direct relationship between what is happening and there is a relationship with the problems with the brain. Now, we know all about these features of infantile. I need not to go into the detail. Now, there are certain functional deficits in infantile esotropia, like we have absence of motor fusion, absence of pore stereopsis, alternating monocular suppression, subnormal VPs, asymmetric monocular tracking, and asymmetric motion perception. So, all this will be there if we don't rectify it in time. So, early surgery is crucial. Very early surgery by about 8 months or 6 months, and early surgery by 9 months to 24 months, and late surgery by after 2 years, which is not going to restore the sensory and motor aspects fully. Now, there are only prospective and retrospective studies. There are no RCTs on this. Between early and late surgeries, there is experimental clinical studies established that very early surgery by 6 months almost restores sensory and motor outcomes. Early surgery may restore outcomes, but outcomes suboptimal, and late surgery does not restore sensory and motor outcomes after 2 years. We had these studies which say that by about 2 to 4 months, any ESO which resolves by about 2 to 4 months, maybe it doesn't resolve, it is going to be permanent. So if the ET is more than 40 prism diopters, by about 2 to 4 months, it is very unlikely to resolve. So in such cases, you can do surgery even by 4 months or so. And if you have early alignment, you also have better motor and hand-eye coordination in these cases. This is what happens in India. When they want to get married, they come for surgery, otherwise they don't bother. So practically they become one-eyed because two eyes never work together. Here you can see inferior oblique overaction, which is about 8-year-old child. These will not come if you have done early surgery. DVD, DHD, and oblique overactions will be avoided. Not that they don't happen, but the chance becomes less. This is showing DHD and DVD. You should always keep this in mind, accommodative component and DHD, because these could congeal the presentation and you may do surgery which may be inappropriate. So to conclude, catch them young, no gain by late intervention. Surgery within 6 months, ideal. Delaying surgery beyond 8 months may lead to suboptimal sensory motor outcomes and may need additional surgical procedures for DVD, inferior oblique overaction, and superior oblique overaction. Thank you. Thank you, Professor.
Professor Dadia, sir, would you want to comment something after this? Yeah. And once more, on behalf of the scientific committee of the AIOS, I would like to thank all of you of making it at such a short notice. This program was conceived last Saturday, so just 6 days ago, and so many of you are here. Thank you.
Yeah, good morning, everyone. This is a pleasant morning, and I would like to thank AIOS and Dr. Gogate specifically for giving this wonderful opportunity of cruising on this backwaters of Kerala. Of course, it's a great opportunity. And as Dr. Chathani said, when a person of this repute, Dr. Pandey's repute, says something, you better listen to him. So I would completely agree with you, sir, as far as debate on early versus late surgery infantile esotropia is concerned. Now, the point is that early means how early? So as he himself has pointed out, is it 6 months? Before 6 months? 8 months, 1 year, 2 years, and it continues. The debate continues. We don't know. So the major problem, if we do early surgery, as sir was trying to say, that these issues like IO overactions, DVDs, nystagmus can crop up. But the point is that more often than not, they don't crop up. They are not a new development. They are present there, but often they are missed. They are missed because of problem in assessment. The child is not very cooperative. We don't know what we want to see, and we cannot, grab the attention of a child for very, very long period. So these points are actually missed. The second problem is variability of deviation. We don't know how the deviation will change. And as sir quoted, that the congenital esotropia observation study themselves has said that the deviation may change over time. So you don't know, you don't have a target for what kind of surgery or for what amount of deviation you want to do a surgery. The second problem is many of them will spontaneously resolve. So a lot of them may actually end up in consecutive exotropias. So this problem is definitely there. So as sir quoted, congenital esotropia observational study. Now this was a big study. They included a lot of, I think 300 patients or so. And they themselves said that not all patients require surgery. So there are only certain characteristics like, if the esotropia persists after 6 months of age, if the angle of deviation is more than 40 prisms, if there is refractive error, which is more than +3 diopter, these are all indications, or these are all signs to tell us that probably these patients are not the patient those are going to resolve. Yes, surgery in this patient still makes sense. But the number of these patients are so less that the subsequent study, which was planned subsequently to CEOS, had to be abandoned because they did not get the enough numbers to randomize early versus late surgery. So it becomes very difficult to say whether the benefit of the early surgery really overcomes the disadvantage of the assessment and multiple surgeries that are required. Now, this was a very interesting study where they compared the early versus late strabismus surgery study. It was a non-randomized trial. Now, you have to understand, it's a non-randomized, where 200 people with the early surgery and 301 children in the late group were taken. They were just compared. It was a multi-centric study, and they vaguely compared these patients without any randomization, without any fixed protocol. And this is what found that patients who were operated early had very good binocularity. There's no doubt about it. Some binocular single vision was present, but then that came at the cost of multiple resurgeries. So that's one very, very important thing, that you have to subject the patient to multiple surgeries. In fact, the rate of resurgeries in early group was somewhere around 60 to 80% when we compare, when this kind of meta-analysis was done. And in a country like India, where you anyway have patients who lose to follow up very often, and also because there is risk of repeated anesthesia exposure, so all those risks taken into account, it's better that we do as less a number as possible. So, in fact, even though the binocularity bargain is in favor of early surgery, the risk of resurgeries is still high in cases where you operate early. And binocularity, for which we are doing all this, is still an elusive target for infantile esotropia. With that, I rest my case. Thank you.
Professor Dadia, sir, your words of wisdom.
So I think there is controversy in each and every topic of the squint. It is not without controversy. So, but I would like to say that in infantile esotropia, the classical teaching is surgery should be done at the earliest, and it should not be delayed beyond 1 year. And on an average, regarding resurgery, you have to do 2.5 resurgeries in each and every case. So those cases which are going to resolve, they resolve by usually 6 months. So the surgery should not be delayed beyond 1 year of age.
The average surgeries required are about 2.2 for in these cases, because what Dr. Dadia rightly said. So beyond 6 months, there is very little possibility of resolution. So we should take a call by 6 months and do by 8 months, I think, for optimum outcomes.
Professor Deshpande, sir.
Yeah, apart from the development of binocular reflexes, nowadays everybody is concerned, especially the parents, they are concerned about the quality of life of that child. Nobody likes that their child is having any squint. So they are all the time worried. So it's one of the very important point nowadays. Everybody is in favor of these that the surgery should be performed as early as possible.
Yes.
That depends actually on the availability of good anesthetist. That is more important. Also. His physical health and the anesthetist. Both the things are important. Then you
Sure.
can go ahead. Thank you.
Thank you. Thank you, sirs. We have the debate on inferior oblique. So may I please request both the speakers to come. There are snacks and drinks at the back. The drinks are only morning kind of drinks. So, but we have just two more debates, one on the inferior oblique and other on binoc. So if the speakers can come, we can wrap up the debates so that, people can then spend time here and time upstairs having look. The inferior oblique debaters, they just said they had come now. Yeah, horizon. Wait, you are speaking on bication. Go ahead. And who's speaking again? You are. Please. So we have Dr. Yeah, Dr. Samyukta. Please, ma'am. And is Professor Elizabeth here? Yes, ma'am. Oh, yes. I'm sorry, I missed you, Professor. Thank you for coming.
I'll start. Good morning, everyone. Let me use this opportunity to thank all my mentors and AIOC for this wonderful opportunity. So I'll be speaking in favor of resection as the primary procedure in horizontal muscle surgery. So resection has been the standard, time-tested, recognized, and historically proven procedure to strengthen or tighten the rectus extraocular muscles. So here we know a measured length of this inserted tendon muscle complex is excised and the shortened muscle is reattached to the original site of insertion. So this effectively makes it more taut, improving the efficiency by raising it to a higher length tension curve. So what is happening here? There is restriction of rotation away from the muscle. Now the question is why we prefer resection to alternative procedures. Resection is a basic skill which is acquired by any strabismus surgeon. It has got a standard short learning curve and precise surgical dosage guidelines and tables are developed, and these are all evidence-based. So obviously, there is an established efficacy dose effect, and surgeons can actually combine resection procedure with small vertical upshifts or downshifts if they want to correct the associated small vertical deviations. So over time, so many procedures came up to act as a replacement procedure for section. So muscle-to-muscle tucking was tried, but it fell out of favor because of the cheese wiring effect. And then Dr. Wright described the scleral plication procedure, and that has got a revived interest in the recent past. So can plication be a true alternative to resection, and is the available evidence sufficient? So these are the concerns in accepting plication as an alternative. So as we fold the muscle onto itself, there is a hump at the plication site, and there is unpredictability regarding the post-op corrections, variability in planning surgical dosing, long-term follow-up data is yet insufficient, and long-term changes in vascularity needs to be studied in detail. And the question again is, will the effect be maintained once the sutures get absorbed? This is how a hump becomes visible at the post-operative plication site. Even though it is said that it resolves with time, it is a matter of concern, a cosmetic blemish for the patient and a matter of concern for the surgeon also. So there is uncertainty regarding the effectiveness compared to an equivalent amount of muscle resection with alternative procedures. Surgical dosage guidelines are not optimized. We see undercorrection and post-op drips also. So this is one long study which got published in British Journal of Ophthalmology, and they compared the outcomes following resection recession versus plication recession in children with intermittent exotropia. And it was found that the surgical success at post-op year 2 was 55.3% in the resect group and only 27.8% in the recession plication group. So it was concluded that in intermittent exotropia children, the resect procedure presented better surgical outcomes as compared to the plication group. The same study also found that augmentation of surgical dosage by 1 to 1.5 millimeter of the original dosage was required to obtain similar results as with resect procedure, and higher reoperation rates were also noted. Again, in another study, Dr. Wright has reported that plication is slightly less powerful than a standard resection, and he recommended increasing the posterior placement of the suture by 0.5 millimeters. So there is a disagreement regarding the amount of adjustment that has to be made to obtain similar effects. And reversibility has been hailed as an advantage of the alternative procedures. Now, Dr. Wright, in his description of the original procedure, cautions that if at all reversal has to be planned, it has to be done within the first 3 days post-operatively. At the end of 1 month, the site becomes unidentifiable. Unidentifiable means it becomes very difficult to do the reversible procedure. Now, this is another concern, effects on the anterior segment circulation. The studies hitherto done have examined only the immediate effects of plication on anterior segment circulation. So, changes to blood flow may arise later when the folded muscles begin to scar. So, we require serial iris angiogram studies over a longer period of time, many years out from surgery, to really comment on the effects on anterior segment circulation. And we always have this option of doing a vessel sparing surgery in the case of resection. And this is a study conducted by Dr. Hunter himself. He compared the short and long-term changes in ocular alignment after both procedures. They have reported undercorrection and higher reoperation rates. And so many studies have come, they have compared the results between the two procedures. We see that the follow-up duration has not been more than 2 years. So to conclude, more prospective multicentric RCTs with longer follow-up periods are required to take up plication as a real primary alternative to resection. Thank you very much.
Thank you, doctor. That was really good. Now maybe see the rebuttal from Dr. Soumya. So do you do plications or do you do only resection?
Yes, yes.
So first of all, I would like to thank AIOS and Dr. Parikshit especially for having given me this opportunity to speak on this topic. So I just wanted to ask how many of you all are doing plication here? Yeah, so our seniors itself, so that itself proves that most of the time. Yeah. So as we show here, everything needs time, and I would like to quote Winston Churchill here. To improve is to change, and to be perfect is to change often. So definitely, it will take time for us to change into a different procedure. So slide is not moving. Yeah, exactly. So I hope the slides are visible. So here I am debating the most ongoing debate of plication versus resection in horizontal muscle surgery. So what do we have here? So today you know that horizontal muscle surgery is the most common strabismus surgery that is being performed worldwide. And among these horizontal muscle surgeries, the strengthening muscle surgeries that is in view in recent times, what we are doing is resection and plication. And as our seniors have told that we are doing the standard resection procedure long often, and my opponent has already told that resection is being followed even now. So, but today I'm definitely going to prove that plication is better. So I think it's a time for changing into this. So this is what I do. It's application with reinforcement. I would like to thank Pradeep Sharma sir for this new technique, which I've learned from the Indian scenario. And basically what is done here is through what I do is through the limbal root, and you identify the muscle. This is medial rectus muscle, which I have taken. And in the similar way that we do the resection, identify the muscle, identify the points at what point you want to do a resection, and take a partial thickness bite, a full thickness bite on either side of the thing, like the routine resection procedures. The only difference between both of this is that in resection, you're basically cutting the muscle, and in plication, you're folding the muscle to the sclera. So the same thing with the 6-0 vicral, this is the thing. You just take a scleral bite in front of the insertion of the medial rectus. The same thing on the other side. And in this special way, that is a reinforcement technique, what we do is you pass the bite from the points where you have taken. This I have not closed the conjunctiva, and in the end you close the conjunctiva with the 8-0 vicral routinely. So my points in favor of plication, I'm going to deal with these in the following headings. So first of all, the most common dreaded complication, the anterior segment ischemia. We know that anterior segment ischemia is very common, especially when you're including a vertical rectus muscle along with the horizontal muscles. And as a general rule, more than 3 rectus muscles is not done in a single operation, and you do not do a second surgery in less than 6 months of time. And that is why many of the anterior ciliary vessel sparing surgeries have come up. And definitely, plication does spare the anterior ciliary vessels. And this study by Deemer et al. Proves that rectus muscle plication spares the ciliary vessels. So he did an iris angiogram test wherein he showed that when you do a superior rectus, you can see that the in the preoperative area, it's filling defects is not there. But in postoperative, in the superior rectus area, there is a filling defect. This is with recession. And in plication, if you can see the preoperative and postoperative iris angiogram pictures are almost the same. So there's not much of effect on the anterior segment circulation. The second most dreaded complication is lost muscle. And we know that medial rectus is the most commonly lost muscle in strabismus surgery. And why is it? Because there is no intermuscular septum between the medial rectus and oblique muscles, and which makes it very difficult to retrieve the medial rectus. And the main reason being, in rectus, you're cutting the muscle. In plication, you're folding the muscle, so you can avoid that lost muscle there. So better to be safe than sorry. And I don't have to say further with this slide. So, and this study by Lambert has shown that management of a lost muscle is very difficult even in experienced hands. And the other thing is that plication is reversible, as my opponent has already told, reversible within 3 days, definitely. But you do have a chance that you can reverse the procedure within 3 days of what you have done application. So in case of overcorrection, you can always reverse your thing, but do not go beyond it. That's true. And short operating time, which is very much required because you can reduce the GA time. Whenever you're planning a multiple surgeries along with your horizontals, you're planning an oblique. So you can definitely reduce the time of operating. Then less inflammation, less cutting. And with your reinforcement technique, what she had showed was that there was a bump. But with this technique, it is almost a little more flatter. You won't see the bump there. And comparable results. Definitely, plication and resection are comparable. So I would like to quote this study, which has been recently published in 2022 in IJO, Pradeep, with the AIMS group. And they have shown that reinforced medial rectus plication is definitely comparable to that of the resection. And this is a meta-analysis study. And they have studied 7 to 8 papers. And they have also shown that it is comparable to that of the resection. And the advantage of plication is you can always adjust also. And you can also use this as nystagmus surgery. And these are my patients whom I have operated. I have been doing this since around 2 to 3 years with the same reinforcement technique. And I've definitely found good results with it. This is a large angle exotropia. This is with a V pattern exotropia. And to conclude, I would say plication is safer than resection. Additional advantage of adding a third muscle in the same setting. In case of operating a previously operated eye, the risk of anterior segment ischemia is reduced. And it's less invasive, less surgical trauma, bleeding, and inflammation. Thank you, one and all. And therefore, it's definitely time to change. Thanks.
Thank you, Doctor. That was a very succinct presentation. Professor Dadia, sir.
So basically, only problem with this plication is that hump is there. So that is the one of the major drawback with this. Effectivity wise, there are various reports in the literature. It is equally effective. So basically, I think with the experience, if the persons they do this plication on long-term basis, the results will be equivocal. But I reserve this procedure only for those cases in which I want to do this adjustable surgeries.
Thank you. Now we have Dr. Elizabeth Joseph, one of the senior most pediatric ophthalmologists from Kerala, speaking for conventional patching. And against her will be my senior from BJ Medical, Dr. Prasad Vaimbe, who was trained in Arvind under Dr. Vijay Lakshmi for Binox. So over to you, ma'am.
Good morning, everyone. I'm really honored to be here. I'm especially thanking Dr. Parikshit for inviting me. And I am to discuss about a debate about conventional patching versus Binox for amblyopia. All of us are strabismus surgeons, and we know what amblyopia is and such a the magnitude of patients having amblyopia. So what is Binoc? Binox is a new software for binocular vision assessment and therapy. It has got both diagnostic modules and therapeutic modules, and it is now being used for treatment of amblyopia. I don't have to discuss about patching because all of us know what patching is. Let us compare the advantages, disadvantages of both these. Patching is traditional, time tested, simple, cost effective, and it is more effective in children, but adults also it is useful. The main difference between these two is that in patching only one eye is stimulated. You are covering one eye, only the other eye is stimulated. And the one main advantage of patching is that it can be used in very small babies, like a 6-month-old, 7-month-old, less than 1 year, less than 2 years. In those children, patching is definitely superior to Binox. Binox cannot be used in small children. And amblyopia has to be addressed at a younger age. Don't wait for these children to grow and then treat amblyopia. Nowadays, people are aware of strabismus. They come early to us. We get patients at 6 months and 4 months of age with esotropia. Even in infantile esotropia, there may be some fixation disparity. Then there may be an amblyopia which we are not able to diagnose. Then also we give patching. That is the biggest advantage of patching. And what about Binox? Binox is new. It has to stand the test of time. It is expensive. It's equally effective in children and adults, just like patching. The main difference is that it is a dichoptic treatment where both eyes are stimulated. We all know that amblyopia is not a uniocular problem, it is a binocular problem, and we have to treat both eyes together. That is the current concept that we all know. And this requires costly equipment. You have to have the special glasses. As I have already told, the main advantage of patching is that it can be used in younger patients, simple, affordable. But the most important disadvantage is that there is issue of compliance and emotional stress. In Binox, the disadvantage is that the child has to be old enough to play with the computer game. The child and the parents have to be rich enough to buy the system, and the parents should be educated enough to understand the mechanism of the games. That is the main disadvantage. And we all know that amblyopia is difficult to treat. There are so many new methods have come. So we are all for change. When a new method comes, we all go for the change and grab the opportunity. Remember CAM stimulator. When I started my training in pediatric ophthalmology, then CAM stimulator had come in a big way. And where is CAM now? It is gone out. So just like that, this new instrument also has to stand the test of time. And at this point of time, we look for clinical evidence. What is the evidence? Whether this binocular treatment is superior to patching. Actually, I looked at the literature. Many randomized control studies are not available to show that this is superior. There are so many studies available showing that the results are almost equal. But none of the study I could find saying that Binox is superior. See, I looked at the American Academy of Ophthalmology, one latest publication published in October 25, 2022. They have compared dichoptic home treatment of amblyopia, a multicentric randomized clinical trial, and there is a American Academy of Ophthalmology Technology Assessment Committee. They have declared that there is no consistent evidence to support the use of binocular therapy over standard treatment based on the PEDIC randomized control studies. And we showed that no superiority of binocular therapy over conventional therapy. But this binocular therapy has got a high adherence provided, and so it provides an alternate treatment. That is the American Academy of Ophthalmic Technology Assessment Committee's report. And I looked at the American Academy preferred practice pattern, which was published in 2022. That is the titled Amblyopia Preferred Practice Pattern 2022. And their recommendation, this I'm quoting from their publication, recommendation to first and foremost recommendation in amblyopia treatment is to correct the refractive errors. And most children with moderate amblyopia respond to initial treatment of 2 hours of daily patching or weekend atropine. And this can be increased later to 6 hours if improvement is not good enough. Higher hours of patching is met with bad complaints, they say. If still there is no improvement, revisit the diagnosis, look at a retina, and only then they recommend additional methods like dichoptic training. So at this point, I will conclude my talk saying that patching is going to stay. None of us are against science advances, changes that is happening, but patching is going to stay, and patching is the primary line of treatment in strabismic and anisometropic amblyopia. And in children who are not compliant with patching or not improving with patching, go for alternate treatment. Thank you very much.
Thank you, madam. Yeah, you can put it. Madam, can निकाल नहीं इसको ही करना एडवांस कैसा ऐसा करना है स्कैन
put in mind.
Screws debates and I want to run this thing also नहीं अभी मत रन करो पहला ये बायनॉक्स का और बाद में ये रन करना है ये वीडियो नीचे करके रखेंगे क्या
जी
अभी जोड़ The history of AIOS, that's the debates and the scientific deliberations are on the cruise.
मैं समय हूँ
बंद करो. So I think my job is made much easier by Madam Elizabeth Madam, because she has already told about the Binox. So it's actually a new frontier in the management of amblyopia. Now let me clear that I don't have any financial, I don't have any shares or this thing for this product. So before starting, let us go to the basic questions, that why do you need newer modalities of treatment for management of amblyopia? Because patching is there since time immemorial. I think the first documented evidence of patching was there in 900 AD. I think one of the I think physicians that time that had there is an evidence that he has started patching in Mesopotamia. But the fact remains that so many new treatments have come itself indicates that it's not the only treatment. There is still scope for improvement. So main thing is patching is a monocular approach, whereas Binox has got a binocular approach. As we all know, as Madam also said, that amblyopia is now recognized as a binocular problem and not a uniocular problem. And so newer treatment modalities aim at treating both eyes together. So what are the shortcomings in monocular approach like patching? Obviously, there is a poor compliance. I know because my kid had amblyopia, so I know how difficult it is to patch. There is a poor compliance. There are always issues of residual amblyopia and recurrence of amblyopia if you abruptly stop patching, if there is no tapering. We cannot treat stereopsis. There are deficits in stereopsis, and obviously it's ineffective in adults. So what is Binox? Just to summarize, it's basically a uniquely designed dioptic software for binocular vision assessment and therapy. It has got diagnostic as well as therapeutic modules, and the therapeutic modules treats the amblyopia. What it requires is, since it's a cloud-based comprehensive software, so what you require is just a desktop or a laptop with a Google Chrome browser, and either Google Meet or Teams or Zoom, which is installed in it, and a good internet connectivity. Till few years back, we always used to say that mobile is a luxury, but now everyone, even the shopkeeper has a mobile. So similarly, in near future, I do expect that most of them will have either the laptops or the desktops, and it will be an easy treatment for amblyopia. And one good advantage of Binox is that therapist and patient may not be in the same sitting. He can even remotely administer Binox. Patient has to use anaglyph goggles. They are either red, blue, or red cyan. After doing one-time calibrations, usually you give 30 sessions of 30 minutes per day of Binox. So these are the very interesting games, and take it from me, they are very quite interesting. Kids get glued to that. There are various games, and since it's a binocular treatment, usually they improve also fast. So what are the advantages? Excellent compliance, since the kids are on the computer, they are playing with the games. There is faster improvement in visual acuity. Main thing is restoration of binocular vision. In some of the patients it's good, some of the patients it's part, but yes, there is an improvement in binocular vision, and most importantly, it's effective in an older age group also. And obviously no recurrences. Since it's a cloud-based software, again it's a user-friendly. In fact, I myself used it. It was quite useful during COVID pandemic, in which the patients were not able to come to the clinics, and even from the distance, the therapist, he can administer Binox, and obviously it is quite useful for patching resistant and patching non-compliant amyloids. And one more advantage is the examiner can even remotely monitor the examination as well as the progress of amblyopia also. But there are some limitations of the Binox also. You have to correct the manifest strabismus before giving Binox. In microtrophy also there is a guarded prognosis that has to be clearly mentioned to the patient. And in presence of eccentric fixation also, there is not much of an improvement. So these are various research papers which I have come across as far as Binox is concerned. In fact, one of the paper, Dr. Elizabeth also mentioned about Dr. Burton Kushner is one of the pioneer in strabismology and amblyopia also. So he has also mentioned it's an alternative treatment. So I agree to you that patching is going to stay, but these are the various new modalities of treatment. And again, I'm repeating my last slide because future belongs to those who believe in change. So to conclude, Binox is an effective and useful treatment for management of amblyopia, and obvious advantages are it has got a binocular approach as compared to unicular approach in patching, excellent compliance, it restores binocular single vision. That's the one of the important thing. Also effective in older age group, and it's useful in patching resistant and patching non-compliant patients. Can we just run the video? A brief video about Binox, and again stating the importance of new treatments which come with time. Mute. Unmute. Whenever any new treatment comes, there are always two reactions from the clinicians. Either one reaction is you always discard it, ये बिल्कुल नहीं चलेगा, ये गलत है. And the second reaction is this is the gold standard, it is going to stay, and that is the only treatment. I think as learned physicians, we should always put all these tests to stringent clinical tests.
उन्हें बदल देता है.
And if it stands the test of time, we should adopt it. Again, importance of time.
मेरा जन्म सृष्टि के निर्माण के साथ हुआ था.
This used to be a famous dialogue during our
युग में हूँ और आने वाले सभी युगों में रहूंगा. और जो समय के साथ बदलते नहीं, समय उन्हें बदल देता है. और आज एक बार फिर समय बदल रहा है. ये बताने से पहले कि आने वाला कल कितना सुनहरा होगा, मैं आपसे 3 जरूरी प्रश्न पूछना चाहता हूं. 1, क्या आप इस करवट लेते युग के साथ खुद को बदलने की हिम्मत रखते हैं? 2, क्या आप हमेशा शिखर पर रहना चाहते हैं? और 3, क्या आप समय के साथ बदलने को तैयार हैं? अगर आपका उत्तर है हां, तो जान लीजिए कि कल की सफलता, आज की जीत और आने वाले कल की कामयाबी के पीछे बस एक ही रणनीति है, और वो है परिवर्तन. परिवर्तन पहले सोच में, फिर अमल में. अगर आप मेरे साथ हैं तो यूं समझिए वक्त आपके साथ है. फिर कल, आज और कल बस आप ही होंगे सफल.
Thank you for your kind attention. So I think the take home message is yes, the patching is going to stay. These are the new treatments. If it stands the test of time, we'll adopt it. Thank you.
So basically, this various treatment modalities, they have been compared with patching, that itself qualifies that patching is going to stay. That is the primary line of treatment. However, in resistant cases and those who can afford, we should try these new technologies.
Thank you. And again, on behalf of the AIOS, I would like to thank all of you for participating in the session. I think we just have another 5 minutes more before we'll be back. So please enjoy the cruise. Thank you. Yes, with everybody.